All right, so my charge was this ugly combination of problems here. I'm going to move fast to the introductory stuff, but basically with these distal tibias and neuropaths and vascular paths, I want to look at what's happening here in the middle with all these combination of problems, and they all have comorbidities, and I think it's pretty much accepted that uncomplicated diabetics do fairly well, as well as non-diabetics, but it's this group with real complicated diabetes that we have really concern with what works and what doesn't work, and high rates of complications with both operative and non-operative treatment. No convincing data. So we're all pretty familiar with the phases of neuropathy here, the necessity for alignment to allow the fracture to essentially congeal. These can sometimes be misinterpreted as infection because of the typical hyperemia. And one of the newer trends now is to consider medicinal therapy, including anti-resorptive therapy for these neuropaths. So we have to identify when they're going to happen. Some of the typical things to look for are unusual comminution, poor bone quality. What are the risk factors? We don't really know, but certainly diabetes, and more than that, certainly long-standing diabetes and complicated diabetes. So we have to look for the potential evolution of a Charcot event. We have to provide stability, and that usually requires frequent exams and x-rays. And perhaps that works with contact casting for some of these, but probably more for the midfoot, less so for the ankle, and probably less so for the distal tibia. So these fractures benefit from stabilization despite the obvious risks. So some of the thoughts with fixing these are fix them and even consider shortening to take pressure off soft tissues. Get probably the strongest device you can that won't threaten the soft tissues, potentially permitting weight bearing. And as far as approaches, longitudinal direct to bone, no elevation with wide bridges. So we have a lot of options here from construct perspectives, and I really only describe two or three. And let's starting with the retrocalcaneal nails. There's some support for these tibial tailor nails, and I've used them in the past for both distal tibia and certainly for ankle fractures. It's only really suited for a select population, usually the elderly. Usually we don't have to go for formal fusion. We don't really have to fear construct breakage or failure, but in a younger population, we certainly would have to go with formal fusion. And we usually want to use longer nails rather than shorter nails. So for acute trauma, hindfoot nailing does have a role, and we've had some real success for fragility fractures. And then I've used it also for high energy distal tibia fractures with success, but maybe there's a role for distal tibia fractures, the charge for my talk here. And there's some observational studies that suggest that maybe hindfoot nailing is a thought for these fragility fractures and osteoporotics and diabetics. What about novel constructs? Well, this is a case that was sent to me. Poor skin quality, which is typical for these low energy open ankle fractures in some of these octogenarians. Typically, they're brought out to length, soft tissue defect. And what do you do with these? You have a combination of problems. So you can use a comb technique, which is transsyndesmotic fixation of screws above and below. It was originally described for diabetics, which we're talking about now in valgus fractures, but it has been applied to higher energy lesions. This was a case of mine here where we don't have to further threaten the medial soft tissues. So it's been documented and it's been charted. It's been worked well in my practice for some of these vascular paths and diabetics. You really want to get forecortical fixation above and below, a good working length, and you occasionally have to go off axis with locking screws to get the trajectory into the syndesmosis, but this is an example of a case of mine here. So I think there's a role for these comb techniques. As far as novel techniques, and I've used these for these low energy open fractures in diabetics, it's very fragile skin. Typically, even in spite of a low energy injury, a medial wound, they don't approximate. They're hard to close, usually not a candidate for a free flap. So there is a possibility for desired shortening of the limb in these vascular paths in diabetics. This is a young patient. I did not want to shorten him, but instead we brought him out to length. We wanted to keep him, but typically what happens is the residents say we were able to close the wound. They were only able to close the wound because they shortened the limb. When you start to do your reconstruction and you bring it out to length, you have this reality. He got a free flap and I fixed him from behind. This is a younger patient, and contrast that to a similar case in a bad host with a low energy fracture. Again, a medial wound that was closed by the residents in an X-fix, but as soon as you bring it out to length, the vascular team says we can't offer much. I went posterior in this case. I shortened both the fibula and the tibia, and we're able to get closure without the necessity for a free flap with an aseptic result. So I think those are some of the thoughts I have for these. This is a case that's a little bit of both, a bad host, a low energy fracture, a diabetic. Again, the wound was closed as soon as you bring it out to length. you have a problem, you need the services of a plastic surgeon who may not be of the option to offer much. So we did a combination of both shortening and a comb technique in this case. So we got him healed without infection. So in conclusion, I think these neuropaths and diabetics, it's a very complicated problem for both the patient and the surgeon. It can be a real calamity. The concerns of physicians are often unaware of the reality here. Diagnosis sometimes delayed, and patients often have an indifference. I think adequate internal fixation can be achieved, is beneficial, but you must address the underlying pathophysiology. Total contact casting, I think, is more for the midfoot, less for the ankle, and probably certainly not for the distal tibia. I think hindfoot nailing is an acceptable treatment that's coming into vogue for good reasons with some real support. Outcome studies are supporting it. And I think these are some of the techniques and the constructs you may consider in some of these very complicated limbs and patients with comorbidities. Thank you.